Good afternoon. Welcome back to our Facebook Live Mondays for Breast Cancer Awareness Month. Thanks so much for joining us again. I am Dr. Susan Boolbol, the Chief of Breast Surgical Oncology and Breast Program at Nuvance Health. And with us today, we have the honor of having Dr. Madhavi Raghu, who is the Chief of Breast Imaging at Nuvance Health on all the Connecticut campuses. Thank you, Dr. Raghu, for joining us today for this important topic on breast imaging. How are you?
Thank you. Thank you, Dr. Boolbol. I'm very excited to be here, and this is a great event. I am doing well and very excited to speak about Breast Cancer Awareness Month.
Fantastic. Let's start off with the basics. What is a mammogram and why is there so much confusion around it?
So a mammogram is a low-dose X-ray of the breast. When a patient comes in, we obtain typically 2 views of each breast, and then those images are now digitally obtained, and in many sites, we actually offer tomosynthesis. Those images are then interpreted by a specialized physician who specializes in breast imaging. The reason there's so much controversy related to mammograms in general is because a small proportion of patients do get called back. And there is some confusion as to what these false positives entail. We know that many patients experience cost and time away from work when they have to return for additional imaging. But the reality is, the majority of mammograms are normal, and mammograms save lives. The whole point here is to find screening cancers, breast cancers, very early on, before they're clinically apparent, before you can actually feel them.
So it's interesting because in my practice, I frequently will see women who have just been diagnosed with breast cancer. And one of the questions is, how did this happen? I get my mammograms every year. And the explanation is mammograms don't prevent breast cancer. Their job is to diagnose it. So how important is early diagnosis with breast cancer?
So early diagnosis is critical. I mean, that is, you know this better than I do. I mean, the survival odds are far better when we find these cancers earlier. And the reality is that, we recommend annual screening mammography in the average risk of women starting at age 40. So if someone has a higher or increased risk for breast cancer, they may need to start earlier. But the important thing here to remember is to come every year.
And so it's starting at 40 and every year.
Every year. What we've seen partially through the pandemic, really, and due to a variety of other factors, is that annual screening mammogram paradigm has really gone on the back burner. So sometimes patients are not truly coming in every year. They may be coming every other year or every couple of years or 3 years. So we really encourage yearly screening mammograms because that's the best way to find cancers early.
So there was a lot of confusion years ago. The guidelines seem to have changed to don't start at 40, you don't need them. Go ahead and start at 50, and you don't need it every year. Go ahead and get it every other year. And that was put out by the U.S. Preventative Task Force, which is an interesting name since
Right.
They decrease the screening guidelines frequently. Why is that? It's confusing to us in the medical field, never mind, the public that are not in the medical field. So everyone's looking at the same data set and coming to the conclusion that screening mammograms absolutely save lives. That whole panel that said, oh, don't get them till 50, also said, without a doubt, screening mammograms save lives. So why the change?
So, I think it's a really good question.
Well, thank you.
So I think a lot of the data and a lot of the guidelines that led to biannual screenings or every other year, or maybe starting at 45 or 50, were based on data that were done years and years ago. And many of those patients that were included were typically between age 40 and 74. And these were the gold standard randomized controlled trial. Mm-hmm. But what we've learned in the past decade is that there's a tremendous amount of power also in these what are called retrospective studies, meaning that we look at a whole population that has received a certain type of treatment, maybe, screening starting at 40 and continuing until the patient is feeling well, so well beyond 74. And then we kind of look back at the data and see how have we performed, are we finding the appropriate number of cancers, are we recalling an appropriate number of patients. So the US task force has based a lot of their guidelines on the randomized controlled trials, which is not an incorrect thing to do. However, there's more data out there that would substantiate the need to start screening at age 40 and to continue annually. So this data is evolving and changing, but those are the guidelines that we practice with, because those have the best outcomes.
Right. And most societies that deal with breast cancer recommend 40 and every year after that. One of the interesting things about the US Task Force in their recommendations released years ago saying at 50, one of the reasons was that mammograms cause anxiety. And it's a lot of anxiety for women. I don't know. I think that we can handle a lot of anxiety as women, and we can decide what our own anxiety levels should be rather than a task force changing recommendations based on that. So along the lines of mammograms, if a woman's told that she has dense breasts, what do we do anything different? Is it just a fact that we know and we move on, or should we be doing something different?
So if a patient has dense breast tissue, first of all, that notification of density is conveyed to the patient. So the patient is educated and informed about what breast density means and what does it mean to the patient in terms of risk. What are they at increased risk? So, patients with extremely dense breast tissue are at increased risk of breast cancer, and even with heterogeneously dense breast tissue, they may be at increased risk for a variety of reasons. One, just for the existence of dense breast tissue, but the other reason is because of this masking effect, meaning that it may hide cancers that may be difficult to perceive on the mammogram. So these patients are actually eligible for supplemental screening, meaning additional screening, and typically it's done with ultrasound, which does not involve any radiation. And so in the state of Connecticut, which really pioneered, made headway in screening ultrasound, patients are notified about their breast density. And certainly at Nuvance, patients are invited to screen with ultrasound as well, in addition to mammography. For a small subset of patients also who are at additional increased risk for other factors, they may also choose to screen with breast MRI.
So just so everyone understands, having dense breast is actually not in our control. And what it really means is that you have more breast tissue than fatty tissue. And the significance, as Dr. Raghu said, is that it is a minor risk factor for breast cancer, but it also makes mammograms more difficult to interpret. And that's because on a mammogram, breast tissue shows up as white, fatty tissue shows up as gray or black, masses frequently show up as white. So when we're looking for a white mass on a white background, much harder to find than a white mass on a black or gray background. And that's why with dense breast tissue, screening mammograms are more difficult to interpret. And we do recommend an ultrasound in addition, not instead of, but in addition to that mammogram. Dr. Raghu, anything else with that?
So the corollary to that really is that patients who have predominantly fatty breasts don't really benefit from screening ultrasound. And the reason for that is because on the ultrasound, women with fatty breasts, that generally everything looks kind of grayish, and cancers look black or dark with the shadowing appearance. And that might be really hard to perceive in patients who do not have dense breast tissue. So sometimes patients ask for the ultrasound, and truly there is limited benefit in those patients. If anything, we're just doing a test and we may not necessarily see anything more that needs to be seen. But patients with extremely dense breast tissue really benefit from that, because on ultrasound, the breast tissue that's dense looks kind of light gray, but cancers are black. So we can perceive that contrast really well on ultrasound as well.
And how does one find out if they have dense breast tissue?
So, breast density is determined by the mammogram. So after the mammogram is performed, there is an interpretation. Patients are notified by letter of their results. And along with those results is also an explanation of the breast density and the options to seek additional imaging if needed.
So if I know that I have dense breast tissue, I find that out this year. When I go for my mammogram next year, should I at the same time have a mammogram and ultrasound? Is that what you recommend?
Well, you can, it's an interesting question because when screening ultrasound initially was proposed and came out and we started offering it to many patients, the question really became, should a patient have the screening ultrasound at the time of the screening mammogram, or should they delay it by 6 months? Or what is the optimal time schedule? And really it comes down to how many cancers are found, whether the screening mammogram is done at the same time or if they're separated out by 6 months. And, the literature really doesn't suggest that there's a significant difference. So it really depends. I say it's up to the patients. It depends on how convenient it is for the patient. Many patients opt to do them together just because it's sort of a one-stop.
Yeah, I don't want to take another day off of work
That's
to
right.
go get something
No,
else. I'd rather take a day off to enjoy it rather than go get an ultrasound or a mammogram. So it is possible to do it all in one day.
Right. And if a patient had a prior mammogram that showed dense breasts, typically they'll come back and, we try to respect that same schedule that they had the year before. So we'll try to schedule both of them on the same day. Now, if a patient does not have dense breast tissue, which evolves and changes, right? So sometimes I say as we mature and get wiser, the breast density will also change and may not be as dense as it used to. So then we won't do the ultrasound, but we do notify the patient that, the breast density has changed. You no longer meet the criteria for breast ultrasound and therefore may not be needed.
So you brought up radiation, that the ultrasound does not have any radiation. We hear frequently, oh, I'm not getting a mammogram because I don't want the radiation. It concerns me. I had one last year. I don't want any more radiation. What really is the truth about radiation and mammograms? Is it something to be concerned about? Not so much? What's your thoughts?
So mammograms, first of all, we know they save lives, but also they're safe. They're extremely safe. We encourage women to get yearly screening mammograms. The radiation associated with screening mammograms is extremely low. Probably get more radiation flying in an airplane, So it's really important to keep that sort of perspective in mind. Also, no one has ever developed a breast cancer from having yearly screening mammograms. It has never happened and it's not documented. So the benefits of actually having screening mammograms far outweigh any potential concerns, especially any related to radiation. If anything, patients are typically concerned about, losing their time at work because they have to come back for additional imaging or potentially a biopsy, which are all understandable. However, the actual radiation associated with with a mammogram is minimal.
Yeah, the American Cancer Society years ago came out and said that you actually get more radiation flying from the East Coast to the West Coast than you do from a mammogram. And I mean, it's COVID, so people hesitate doing that, but pre-COVID, no one hesitated doing that because of the radiation.
Exactly.
So I think it's a reasonable comparison. It actually puts it into terms that we can understand. And we actually typically don't think about radiation exposure when we get on an airplane.
Exactly. We enjoy ourselves when we get on an airplane.
It's pretty safe. So let's talk about some other things that women hesitate with mammograms. And they'll say, oh, it's so uncomfortable. It was painful. What do we do about that? And that does prevent some women or adds to the reasons why women don't get mammograms. What's your thoughts on that?
Well, listen, mammograms, I can understand they can be uncomfortable, but
we get them.
We get them. Again, they save lives. How many times have we said that already? But I really think patients should first and foremost, when they choose to go to a facility for a mammogram, they should be electing to choose a site that is a dedicated breast center. Nuvance has several such dedicated breast centers because these centers are staffed by technologists who are really well versed in making sure that patients can tolerate the procedure, can go through it very well, and they know how to position patients, they work with patients, they know how to make them comfortable, they know how to optimize the imaging. And we as the radiologists are we want the best possible images so that we can actually get the best possible interpretation slash the most accurate interpretation. And sometimes that does involve pressure, but our technologists are the true people at the forefront who work with patients and make sure that they're really comfortable. So a majority of patients actually do have a comfortable experience in terms of getting their mammogram, and our technologists are extremely good in working with them to make sure that they're comfortable during the entire procedure. Now, we also are doing, tomosynthesis is the standard of care here. And so it's actually—
Is that the same thing as 3D mammograms?
That's right, it's the same thing. And so the sweeps through each breast are just a few seconds. It's been optimized so that, we know that patients, sometimes they're coming in, they may be wearing a mask. It may be hard for them to hold their breath. So we want to make sure that study is done quickly, accurately, and comfortably. And this technology allows us to do that.
And do you find 3D mammograms in most imaging centers at this point, or not all?
It's becoming slowly creeping up to becoming the standard of care at different facilities. I know that here at Nuvance, it's offered everywhere, and we offer it to patients regardless of their age, their breast density, their history. They're basically getting screened with tomosynthesis, which is really it's like leafing through pages of a book, thin slices through the breast so that we can actually find lesions that may be hiding behind dense tissue or other tissue.
So 3D mammograms then essentially are more accurate.
They are more accurate. They also allow us, so they're more accurate in the sense that allow us to find cancers better. So there's actually an increase in the cancer detection rate with tomosynthesis, about 20 to 30% over just—
So does that mean you're finding it earlier than you would on a 2D mammogram?
Exactly. Especially
so
in
why
women.
would anyone go any place that doesn't have 3D mammograms?
Well, listen, that's exactly what I say too.
I guess that's why we're here.
That's right. But, and especially in women with dense breast tissue, you can imagine that tomosynthesis actually allows us to find these cancers. The other benefit of tomo is it cuts down on the false positives. So when we actually call patients back, first of all, we call fewer patients back, which is a good thing. And secondly—
that's a scary thing to get that phone call.
Of course.
It's a very scary thing.
And when we do call patients back, it's with a little bit more of a reasonable accuracy in terms of what we're looking for.
So who reads mammograms? Radiologists? How do I know who's reading my mammogram? Because most people don't even know the name of their radiologist.
Well, that's a shame.
They talk to the tech.
Yes.
Right? In the room, they don't really meet the radiologist.
I know. I understand that. But we're changing all of that, okay? Because first of all, a radiologist is a physician. I think a lot of patients actually don't know that. And I've had many technologists in years past say to me, the patient wanted me to read their mammogram. Our technologists are highly skilled, but they're not going to interpret the study. So the radiologists have gone to medical school. They've actually had some additional training in radiology, about 5 years. And then on top of that, many of us elect to get specialized or training or fellowship in breast imaging. And what we're trying to do is to really equip our breast centers with fellowship trained breast imagers. Now there is a difference. Of course, we have individuals who've had a tremendous amount of experience reading breast imaging and perhaps may not have had the opportunity for a breast fellowship many years ago. But going forward, breast imaging itself has evolved significantly, especially with tomosynthesis and breast MRI. So it's really important to make sure that the person reading the mammogram is well versed in all of the current technology and updates. And that typically means somebody who is fellowship trained.
So as a patient, how do I know these things and what questions should I ask?
Well, I think it's very important for a patient when they go into a new breast center, ask who is reading these studies. This day and age, basically patients, the physician bios are available on the websites, so it's very easy to peruse through that and really determine who's actually reading the studies. I've also had many patients actually ask to speak to the radiologist. And so, at Nuvance, we offer patients the opportunity to speak to the physicians if they wish to. Now, there's a subset of patients who come in, get their screening mammogram, and they're going to go home. That's totally fine. But we want to really engage with the patient and offer them the opportunity to speak and ask questions of their radiologist, because these may be questions that may or may not be able to be answered by a primary care physician or an OBGYN. And this is what we do, this is what we do day in and day out. So even to discuss what a callback is, what is the difference between a 2D mammogram and a 3D mammogram? These are all questions that a well-trained breast radiologist can definitely answer.
So far, my takeaways as a patient are ask if they have 3D mammograms.
Correct.
And ask who the doctor reading my mammogram is going to be, and are they fellowship trained breast imagers? Is that correct so far?
Correct.
Okay, so the first of many, or the first two of many take-home messages for our audience today. Ask about 3D mammograms. That is what you want, and you want a fellowship trained breast imager reading your mammogram, or someone with decades of experience who's been around longer than breast imaging fellowships.
That's right. That's right.
Okay.
Really important.
So you've mentioned several times screening mammograms. Are there different types of mammograms?
Well, a mammogram is a mammogram. However, there may be reasons why a patient may obtain a mammogram. So, a screening mammogram is typically reserved for individuals who have absolutely no symptoms of breast cancer. So they don't have a lump, they don't have anything that they're feeling. It's a true screening study, and we typically get 2 views of each breast.
So that's what we get every year?
Every year.
No problems, just go in for your screening mammogram. Okay. And can I talk to my radiologist at the time of the screening mammogram, or no?
Yeah, in most cases you can, unless it's done at night. Sometimes we offer evening, many places we offer evening hours, and there may not be a radiologist on site for those studies. But if it's done during the daytime, I've had many patients say, I just want to either get my results read right then and there, or can I just talk to the person who's going to read my mammogram? Totally reasonable. The second type of mammogram really is the diagnostic mammogram, which is again, it's the same tomosynthesis, it's the same exact machine equipment, even the same technologists perform it, but we might look at specific parts of the breast. Maybe we're only going to focus in on the upper outer breast, or we're going to look in at the medial or the inner breast. Sometimes we magnify a particular area of the breast because we're looking at calcification. So it really depends on the reason. So the reasons for a diagnostic mammogram may be the patient is coming back because they have an abnormality on the screening mammogram, or maybe they have a clinical symptom like a lump. And so we're going to look a little bit more carefully at a particular area of the breast. Or sometimes patients came in, several months ago, had a mammogram, and we decided that they should come back in 6 months just to keep an eye on an area. So those patients will also get specific views of the breast. So I want to emphasize it's the same equipment. It's just that the views might change, and what part of the breast we look at may vary.
Okay. We're going to get back into that 6-month follow-up in a minute, but before that, you touched on an MRI. What is that? And it doesn't sound like it's a fun test. Is it like an MRI of your knee or your shoulder?
Yeah, the MRI technology is, we're not going to get into the physics of the MRI, right? It's the basic, the same type of MRI that any patient will have for a specific body part. And the reason for that is we're looking at what's called, vascular imaging. We're looking to see what the blood flow is going to do to a particular organ. So for a breast MRI, first of all, there's specific indications for it. So someone who may be at increased risk for breast cancer, and there's lots of models out there that will predict how someone may be considered at increased risk. And those patients may come in for a breast MRI, but there are other reasons as well if they're diagnosed with breast cancer and whatnot. But first of all, those have to be done on a specific machine with a dedicated what's called breast coil. So there's got to be real specific parts on there that has to be contoured for the breast. And then patients typically receive contrast. So there's dye that's actually injected into the veins, just as anyone would get an IV. Okay, and that serves as a paint for the breast, and so it allows us to look in the breast and see if there's a cancer or if there's anything that's suspicious or concerning in the breast, and that's considered additional. For some patients, it may be a type of screening in addition to the mammogram, but it can really serve many functions for different patients.
Okay. In the last few minutes, I just want to touch on the 6-month follow-up. I had a screening mammogram and was told I have to come back in 6 months. Is that a bad thing? I know it's not the norm. Should I worry?
So, there is a small number of patients who've been told that they may have to come back in 6 months. First of all, when we put things in that category, we have a very specific number of findings that we can put into that category. Everything that we do in breast imaging is rule bound. We have a lot of rules that we follow when we.
Sounds like life.
That's right. When we dictate, when we decide.
Lots of rules.
Lots of rules. What we are going to biopsy, and so typically whatever we elect to follow in 6 months have to meet certain criteria. And so when we put things in that category, we're actually saying that there's a 98% chance that it's nothing. Okay. So that's a good way to think about it. Whereas if it was less than 98% chance, we would probably recommend a biopsy. But
that's my next question is the biopsy. So if I'm told that I need a biopsy, does that mean I have cancer?
No, absolutely not. It just means that we're not sure. That's really what this is. And I tell patients it's now there's some patients that may have a finding that's highly suspicious, but it's a small number. A majority of patients may undergo a biopsy because we just can't say with certainty that it's nothing. And it is many times we elect to be cautious and conservative to make sure that this may not show cancer. So biopsies are typically performed because we want to make sure that there isn't a cancer that's lurking in that lesion.
So it sounds like the majority of the time that you recommend a biopsy, it is not going to wind up being cancer.
That's right. Majority of the time, especially, it's greater than 50% chance really that more than 50% of our biopsy probably turn out to be nothing. However,
well, that's a good thing.
That's a good thing. However, I would like to emphasize that when a biopsy is recommended, it should be taken seriously and it should be performed because, we're all human and we want to make sure that there isn't something in there.
So in the last minute, are there any other messages and take-home points that you want to get out to our audience on this super important topic?
I think that what we have to remember is that during the pandemic, many of us have put our appointments on the wayside, including screening mammograms, and I'm talking about other healthcare appointments as well. I think that it's really important and critical to get back to those appointments and get back to taking care of ourselves because it's just vastly important to make sure that we find these cancers. It's really important that we go in now every year and get our screening mammograms. Our facilities are very safe, and I can say that our employees are vaccinated. We are very careful about our cleaning procedures that we employ at all the facilities. So I think it's very safe for patients to come back in for their screening mammograms, and we would encourage you to do so.
So if you are 40 and older and hearing this, watching it, however you're getting this information, and you have not had a mammogram in the past year, please schedule the mammogram.
Absolutely.
Get a 3D mammogram and have it read by a fellowship-trained breast imager.
Exactly.
Those are my take-home messages for this afternoon's Facebook Live.
Absolutely. I agree.
Any final words?
Well, I just want to thank you again for bringing to light this important topic, and we look forward to serving our community.
Well, thank you very much. And thank you all for joining us this afternoon, or whenever you happen to be watching this. Again, get your mammograms this year and every year if you are 40 and older and of average risk. There are times where you should be starting earlier than 40, but that's a discussion with your physician. Please join us live next week, next Monday, October 25th, for our Mondays during Breast Cancer Awareness Month. We will be joined by Dr. Lisa Curcio discussing breast cancer risks and how we can change them. Thank you so much. Have a great day. Bye.
Thank you.